Hi, this is E. David Crawford, Editor-in-Chief of Grand Rounds in Urology. Joining me is Dr. Veda Giri, who is an Associate Professor in Medical Oncology, Cancer Biology, and Urology at the Sidney Kimmel Cancer Center at Thomas Jefferson University. Dr. Giri is also Director of the Cancer Risk and Assessment and Clinical Cancer Genetics at Thomas Jefferson. She was one of the first to start a men's genetic risk clinic back in 2014. And we're going to talk to her today about an important conference that she co-hosted in 2017 and recently in 2019 entitled the Philadelphia Prostate Cancer Consensus Conference that addresses a lot of the comprehensive framework of genetic evaluation and so on in prostate cancer. So we're very fortunate to have Veda with us this morning. Thanks for joining us.
Thank you very much. I am delighted to be here today and to give a report on the consensus conference, which was titled Implementation of Germline Testing for Prostate Cancer. And this was from the Philadelphia Prostate Cancer Consensus Conference held in 2019. So very briefly, in terms of background, we know that germline testing for prostate cancer is rapidly increasing. There is a growing clinical role across clinical scenarios, primarily in the metastatic setting with castration-resistant prostate cancer. There have been multiple PARP inhibitors approved with FDA indications, but more excitingly, there were recent FDA approvals for rucaparib and olaparib in the metastatic setting, particularly after a few lines of therapy. There's also an increasing consideration of how germline testing may be included in active surveillance discussions and also in prostate cancer early detection discussions. But very importantly, germline testing has hereditary cancer implications, and this is very important to consider when moving forward with testing. What we noted was that there were several challenges arising with these increasing indications and the rising role of genetic testing for prostate cancer. So that meant that there was an increasing volume of men who were in need of genetic testing. However, the clinical challenge was the variability in testing indications across NCCN panels that include prostate cancer germline testing, increasing genetic data across the stage spectrum that needed to be synthesized, an expansion of genetic laboratories and panel testing options, and then, as we note, increasing demand for genetic counseling and rising healthcare providers that are non-genetically trained in ordering genetic testing, and the need to address germline testing in clinical trials. So we came together as an expert panel and discussed responsible implementation of germline testing and addressed key areas, including defining optimal genetic testing strategies, incorporating the expansion of panel testing options and evolving genetic data, propose consistent genetic testing indications and management, address alternate genetic evaluation models and counseling strategies to address the genetic counseling shortage, and then overall to develop an implementation framework for genetic testing and counseling for men across the stage spectrum and also addressing multiple provider specialties. This was indeed a team effort, and I am grateful to all of our consensus participants who came from around the world to participate in this consensus conference. I have special thanks for my consensus conference co-chairs, Dr. Gamella and Dr. Knudsen as well, for helping in leading this effort along with me. So our consensus voting participants included multiple specialties. There was strong representation of urology, medical oncology, genetic counseling and implementation science, radiation oncology, as well as other disciplines and research areas involved, and patients and patient advocates. This was indeed a global conference that included participants from the United States, Australia, and the UK, and also included representation from various different practice settings. Importantly, multiple organizations were represented as well, very importantly being NCCN panel leaders. This is the implementation framework that was published in the Journal of Clinical Oncology from the Consensus Conference. And I wanted to walk you through some of the highlights of this implementation framework. What you can see here is that the green boxes indicate strong agreement for that particular recommendation, and it was deemed as a recommendation. And then the yellow boxes indicate moderate agreement of 50 to 74%, and that was deemed as a consideration in terms of the various different criteria. And so if we start here on the left side, the purpose of germline testing, we've already talked about this a little bit in terms of the rising clinical role in the metastatic setting for therapeutic decision-making and clinical trial eligibility, in the non-metastatic setting for consideration in active surveillance discussions, and then for men without a diagnosis of prostate cancer in terms of informing prostate cancer early detection or screening discussions. Important to understand that there can be the identification of hereditary cancer syndromes across this particular spectrum of clinical scenarios. As far as indications for germline testing goes, we did achieve strong consensus for recommending that all men with metastatic prostate cancer have germline testing, and this is consistent with current NCCN guidelines. There was also strong consensus for family history that was consistent with hereditary prostate cancer. So for those that have close relatives with prostate cancer, young age at diagnosis, or metastatic disease. There was also a consideration for various pathologic criteria, ancestry criteria, as well as family history criteria for considering cancers that are part of the hereditary breast and ovarian cancer or Lynch syndrome spectrum. We also, as a panel, addressed optimal informed consent and genetic counseling strategies. This is really important so that men can make an informed decision for genetic testing. And I'm going to go into some of these in a little more detail. But importantly, we also addressed various different technologies that can help enhance access to genetic counseling, such as collaborative models, telehealth, and telephone counseling, and the use of videos. But really quickly, just in terms of what should be discussed with men before making an informed decision for genetic testing, I wanted to highlight a couple of the key points. One of these is that there is variability in multi-gene panels that are available for clinical testing. This just gives a cross-section of 10 laboratories that offer clinical multi-gene panel testing. And you can see here that there is a spectrum of the number of genes tested and the actual genes tested. These genes have variability in terms of strength of association to prostate cancer, risk for aggressive disease, and also prevalence in the metastatic setting. There are different panel options as well to consider. So there can be guidelines-focused panels that include a smaller number of genes, 5 to 6 genes. These have management guidelines available. There can be cancer-specific panels, such as a prostate cancer-specific panel that has typically about 10 to 15 genes. And some of these genes have management guidelines associated, while some of them do not. And then comprehensive panels that can have 80 and actually even more than 80 genes at this point in time. And the same issues are here. Some of those genes have management associated and some of them do not. A really unique option that is conducive to collaborating with genetic counseling is reflex testing, where initial genes can be tested that might have management associated, and if they return negative, additional genes can be tested at no cost based on the laboratory. And so that's a nice option to have when thinking about collaborating, ordering genetic testing in a provider space, and then having a genetic counselor complete the genetic evaluation. What you can see here, though, is that the variant of uncertain significance rates go up significantly with the more genes that you test. And that's important for men to understand that as well when making a decision about the type of panel to use. In addition, there can be multiple cancer risks that are uncovered for men and potentially impact their families as well, since we're talking about hereditary cancer testing. So for example, with BRCA2, while we may be thinking of testing a man to inform prostate cancer treatment or risk, if a BRCA2 mutation is found, there can be also additional risks for that male, such as male breast cancer, melanoma, and pancreatic cancer. As well, we know that there are female cancer risks, such as breast cancer, ovarian cancer, but also risks for melanoma and pancreatic cancer. This applies across the genes, as you can see here, so it's really important for men to understand that while we may be testing in the context of prostate cancer, additional cancer risks can be identified. Another important aspect to bring up before genetic testing is ordered is the Gina Law. This is the Genetic Information Non-Discrimination Act of 2008. And this provides protection for patients who have genetic mutations from discrimination in health insurance and employment. But what is important for patients to understand is what is not covered by the Gina Law. Gina does not apply to life insurance, disability, or long-term care insurances. There's other exemptions as well, or there may be special permissions that are needed for other types of health insurance plans. And for example, another area that Gina does not apply to is for small businesses, so those that have fewer than 15 employees. So these are things for men to consider just in terms of their financial security prior to going ahead with genetic testing. So we laid out all of these elements to think about in terms of informed consent in our consensus framework. And then we talked about the gene panels and prioritized genes for testing. So in the metastatic setting, there was strong recommendation for broad germline panel testing to help inform treatment eligibility and clinical trials. Priority genes to include in these panels included BRCA2, BRCA1, and the mismatch repair genes, with consideration of ATM, but really additional genes for clinical trials. In the non-metastatic setting, priority gene was BRCA2 for consideration in active surveillance discussions. And reflex panel testing here was also given a consideration for thinking of an optimal way to have genetic counseling engaged in this process. For unaffected males, the recommendation was that priority genes would be BRCA2 and HOXB13. Again, here, reflex panel testing was thought to be particularly suitable. In terms of precision prostate cancer treatment, management, and early detection, in the metastatic setting, there was strong recommendation for enrollment in precision medicine trials. In terms of the genes, most of the genes that received either recommendations or considerations were BRCA1 and 2 for PARP inhibitor candidacy, the DNA mismatch repair genes for considering therapy with anti-PD-1 therapeutic agents. And then in the active surveillance setting, BRCA2 was given strong recommendations for consideration in active surveillance discussions. And in the early detection setting, referral to specialty prostate cancer high-risk clinics or clinical screening trials was endorsed, and BRCA2 was given a strong recommendation for consideration in early detection discussions. Here we did state that prostate cancer screening could start at 40 or 10 years prior to the youngest prostate cancer diagnosed in a family, just to factor in family history. Additional genes were also given a consideration in the early detection setting. And then when we talk about the post-test disclosure setting, there was a strong recommendation to refer men who have pathogenic or likely pathogenic mutations to a genetic counselor for full disclosure of what that means in terms of cancer risks, and to also coordinate cascade testing in those families. That should really be done in consultation with a genetics professional. Practices should determine how to address disclosure of VUS or negative results in terms of their capacity to handle that discussion, and also if there are special circumstances that warrant that men should be referred to a genetic counselor, such as strong family cancer history, other relatives that might need testing, or patient anxiety. Family history recommendations are also important to deliver. So in summary, this is a really exciting time for germline testing for prostate cancer with a growing clinical role. It is really important that our patients receive optimal informed consent to make an informed decision. Family history is vital in terms of having comprehensive recommendations delivered. And our consensus panel, in addition to developing the implementation framework, also provided priorities for provider education, practice barriers, and research priorities. And I think an important thing is to just have those proactive conversations with genetic counseling so that patient needs and family needs can be addressed. So thank you very much for the opportunity to present on the Philadelphia Prostate Cancer Consensus Conference from 2019.